Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I am pleased to welcome you to the second live session of the day titled Lymphoma Amongst the AYA Population. Just before we start, I do want to go through a few housekeeping items again. So this Zoom software does not allow you to access your camera or your microphone. So if you do have a question, please be sure to enter it in the Q&A chat box option at the bottom of your screen. Additionally, this webinar will be recorded and it will be available on our website shortly after the conference, and you will also receive an email with the links to access these recordings. So with that said, to introduce our speaker today, we have here Dr. Pamela Skrbeck, who is a hematologist at Cancer Care Manitoba. Dr. Skrbeck's research contributions have focused on non-Hodgkin lymphomas with a combination of epidemiological and translational research projects. As lead of the lymphoproliferative disease site group, part of her role is to oversee clinical research activities and collaborate in clinical trials provincially and nationally. She is also a member of Lymphoma Canada's Scientific Advisory Board and is a chair of Lymphoma Canada's Patient and Support Research Committee. So thank you, Dr. Skrbeck, for joining us today, and you could get started as soon as you're ready.
Thanks, Gurjat. And so thank you for having me here today to discuss this topic, which is regarding lymphoma in adolescents and young adults. I'm Dr. Pam Skrbeck, and I will proceed with my presentation. So just as a little bit of an outline, I'm going to first discuss an introduction to this patient population and the lymphomas that they're most commonly diagnosed with, talk about some specific issues relevant to this patient population next, including fertility and then survivorship. As part of survivorship, we'll focus on second cancers as well as some other physical and psychological long-term effects. And so adolescents and young adults. And so this is often abbreviated AYA. This is generally speaking defined as age 15 to 39, but there are some differences at times in the age range that defines this patient group. This is a unique patient population, not just because they're younger, but the cancers that they get are different than either children or older adults. And that is true of the lymphomas that they get as well, in terms of the proportionate frequencies compared to older adults. Lymphoma is one of the more common cancers in the adolescent and young adult patient group. And so it's an important diagnosis to discuss when thinking about this patient population. And there's many reasons why AYA often is considered to be unique, but one is that we really have to think long-term about health effects because people can live for decades and decades post-cancer. And we also have to think about impact on different parts of life that are potentially not as relevant for older patients. So this is some Manitoba data, which basically just breaks down the common cancer types in adolescents and young adults. And this data is fairly consistent in other areas as well. So lymphoma makes up about 15% of cancers in adolescents and young adults. So when we talk about lymphoma in young people, we see both Hodgkin lymphoma and non-Hodgkin lymphoma. And I think that people often first think of Hodgkin lymphoma in younger patients, but overall, non-Hodgkin lymphoma is extremely common as well, as you'll see in the next slide. Proportionately, we see more Hodgkin lymphoma in younger patient population than we do in older age groups, and it's the most common blood cancer in 50 non-Hodgkin, and shows that figures here, which is the most common non-Hodgkin lymphoma overall, so in all age groups, also makes up the largest proportion in the AYA group. But next we have Burkitt's lymphoma, which is a very aggressive or fast-growing type of non-Hodgkin lymphoma. And both Burkitt's as well as lymphoblastic lymphoma, which is another very aggressive, fast-growing type of non-Hodgkin lymphoma, are sort of overrepresented in this younger patient population. So we don't tend to see as much in the older patient groups. Anaplastic large cell lymphoma is a very specific type of T-cell non-Hodgkin lymphoma that is seen more frequently in young patients than it is, or proportionately more frequently than it is in older patients. Also want to just mention primary mediastinal lymphoma, which is very rarely seen outside of the AYA population. And then there's a smatterings of others, which are also very challenging too. So in my practice, for example, I do see occasionally patients that are very, very young, like as young as 19 or early 20s with indolent lymphomas, which are generally a diagnosis made in the mid to late 60s. And so that's challenging because you know, how you approach treating a patient is very different when they're that much younger. So just talking a little bit about challenges more in lymphoma in young patients. So one challenge is that there's not a lot of treatment on clinical trials in this patient population. That's something that that we are hoping to improve. One of the issues with clinical trials is historically they often sort of lump patient in that pediatric category, so 18 and under, and then adult of 18 and over. But really, many teens are, you know, physiologically not that much different than adults, and their lymphomas should probably be treated the same as lymphomas are treated in adults. And so more and more, clinical trials, particularly in Hodgkin lymphoma, have had a broader age distribution. So for example, some of the clinical trials that we've looked at opening recently go down to, for example, age 12 or age 16, rather than starting at age 18. Delay in diagnosis is more common in lymphoma than any other cancer. And in young patients, this seems to be even more prominent. I think largely because cancer is not the first thought when patients present with symptoms when they're young. But we do know that delay in diagnosis is a significant concern for the AYA population with lymphoma. Lymphoma significantly impacts quality of life, and it can impact life expectancy. And so given how many years of life people have left when they're diagnosed with cancers at a young age, this is a unique challenge. There's limited specific support services for AYA patients. And this is something that I think many centers are trying to improve. Manitoba, for example, has a relatively new AYA program that's quite comprehensive and multidisciplinary, and hopefully other places are following suit. One of the other challenges is, as we talked about before, just long-term consequences for survivors of lymphoma. And so this diagram shows all of the different disruptions that can be caused by a cancer diagnosis in adolescents and young adults. And many of these do overlap with patients that are older as well, but some of them are particularly prominent or much more likely in the AYA patient population. I'm going to focus on fertility because that is one of the areas that is more unique in terms of concern for the AYA patient population compared to our general practice in lymphoma for older patient. And so oncofertility is basically when cancer treatment and the medicine of fertility kind of come together. And so why is fertility important? Well, many patients, in fact, the majority of patients who are diagnosed with lymphoma as an adolescent and young adult are going to become a long-term survivor. And many, perhaps not all, but many will wish to have children at some time point. And people's ability to conceive and fertility can be impacted by the treatments that we give them as well. People can have premature ovarian failure from the treatments that we give them. And so it's important to discuss this with patients and provide them with as much information as we can. Studies have shown that only 52% of young adults have had a conversation about fertility preservation with their healthcare provider. And sometimes there isn't a lot of good options for a patient, but having knowledge and having that conversation has a positive psychological impact. And so it's important that it occurs. So talking a little bit more specifically about lymphoma treatments and fertility. So in Hodgkin lymphoma, the most common treatment that we would currently use is ABVD, or now brentuximab vedotin with AVD. This treatment regimen alone is not common to cause permanent infertility. And so that is something that is we can reassure most patients of. However, it's always hard to predict who the small portion of patients are that are not going to respond well to their initial treatment or going to relapse after their initial treatment. And further treatments subsequently will impact fertility more so. Escalated BIACOP is a treatment that is given more commonly in Germany and other parts of the world, initially in Hodgkin lymphoma. In Canada, I think it's generally reserved for escalating when people have not responded well to their initial treatment. This is a regimen that has a high risk of infertility. One of the things that we know from Hodgkin lymphoma, unfortunately, is that that sometimes fertility in males can be impacted even pre-treatment, and so the disease itself can decrease sperm count, and so doesn't mean though that semen cryopreservation can't be helpful. It just means that we have to ensure that we have good samples before we start our treatment. So in non-Hodgkin lymphoma, the treatments are a bit different. For common treatments, so like CHOP, the drug that would generally affect fertility is the C, or the cyclophosphamide. The overall risk of infertility with CHOP alone is low because the total dose of the cyclophosphamide is not that high, but in patients that need more aggressive regimens, so for example, if there's Burkitt's or there's a high-grade lymphoma, we would typically give more of that drug, and the risk of infertility will increase. Also, age at which you receive your treatments will impact fertility risk. So the older a patient is, the more potential impact, and I'll show that in a graph next. Risk of infertility also increases with transplants or any radiation to the pelvis, although we do try, the radiation oncologists try to shield the gonadal tissues as much as possible when they radiate the pelvis. And so this, is just meant to kind of show something that I often try to discuss with patient. So when you're born, you have a specific number of ovarian follicles, And that drops over lifetime normally, to a point where at some point there's a decreased or end of fertility, and at another time point there's menopause that occurs. Chemotherapy will kind of knock this curve lower, and so that everything happens earlier. And to what degree it knocks it lower is a little bit difficult to predict, but the effect is going to be more prominent the older the patient is, and so more likely to sort of push people over that edge into premature menopause. And so just want to talk a moment about fertility preservation. I am not an expert in this, and so generally speaking, I have a preliminary discussion where I offer to refer patients to our fertility clinic in Manitoba, where they can kind of discuss in more detail risk benefits, logistics, cost, all that stuff. But for individuals with ovaries, generally the most common thing that is discussed would be egg cryopreservation, because embryo cryopreservation would require that there is a partner that a patient would be ready to commit to making embryos with, which is not always the case in the adolescent and young adult population of patient. Semen cryopreservation is much more commonly pursued, and I'll talk about why in a moment. Basically, it's just easier from a logistical time point. It can be, from time to referral to completion, can be very short time frame, whereas the process of harvesting an embryo or oocyte can take weeks. And so it's also much, much cheaper sperm cryopreservation than the option. Brings me to talking about barriers to fertility preservation. Cancer at a young age is already a financial hardship for patients. They cannot usually continue to work to the same capacity, if at all. And this fertility preservation is really only covered in the province of Quebec. There is some tax deductions that can be claimed, but people still have to come up with money up front. And it can be very expensive. So for sperm cryopreservation, generally speaking, with the initial consult and the initial preservation, it would be just under $1,000, and then several hundred per year to maintain the specimen. For oocyte or embryo cryopreservation, it can be upwards of $16,000 to $18,000 is my understanding, which is extremely prohibitive for most people. I think another main barrier is that people have to make decisions at a very emotional time. And so you're already meeting with, multiple new care providers to discuss a new cancer diagnosis. It's extremely stressful. Some people haven't thought much about if they want to have children, in the future. And so it's just a tough time to make decisions about fertility. The time delays for starting treatment are a significant barrier, particularly for egg or embryo retrieval. Many patients are too sick to wait that long. And so it's just not even practical, even if they were to have the desire to move forward with that. And another barrier is that, as we discussed before, sometimes these discussions are not necessarily had. So I'm going to move on from fertility and talk a little bit about survivorship care. And so the reason that survivorship care is important to think about is that thankfully most people who are diagnosed with cancers as an adolescent and young adult will live a very long time. And this 5-year survival is very similar for lymphomas as it is for the cancer overall in this age group. And people have decades to live, generally speaking. And so we have to think about all of the potential long-term effects on survivors of the lymphoma at a young age. And so I'm going to focus particularly on second cancers, but the other areas of survivorship are physical effects, psychological effects, and kind of having chronic health conditions. So lymphoma survivors that are at higher risk of second cancer. And so unfortunately, this is as patients sort of, get to that time point. Usually it's approximately 2 years post-treatment of their lymphoma where risk of recurrence is really low. And we can feel, fairly reassured that it's unlikely their lymphoma will recur. Unfortunately, there is a high risk long-term of other cancers. So most commonly, these are breast, colorectal, or lung cancer. And the risk factors are radiation therapy use. And so this is one of the reasons why treatments, particularly in Hodgkin's lymphoma, have shifted to trying to minimize this use of radiation to try to minimize this long-term concern when we can. Age at time of treatment is a risk factor, number of chemotherapies, type of chemotherapies, whether or not patient has a transplant. So just, again, intensity of treatment, as well as there is a thought that possibly that people that are predisposed to lymphomas, maybe they also have a genetic predisposition to cancers, although there's no specific genes that have been identified that sort of prove this or that we can test for. We'll talk a little bit about screening recommendations, lifestyle recommendations, and talk about the 3 most common second cancers. So lung cancer, most of the data for this comes from Hodgkin lymphoma. And a lot of this is from decades ago when treatment fairly uniformly included radiation. And so I hope that we're going to see less second cancer with lung cancer as time goes on. We know that the use of radiation and smoking not only have an additive effect, but it's actually more than additive. And so being a smoker, if you've had radiation to the lungs, is very much increases the risk of lung cancer. And there's a benefit of stopping smoking at any point to decrease that cancer risk. There isn't specific guidelines about screening for patients who have had a history of lymphoma and are at higher risk. There are some general population screening guidelines, and so that would what we would generally follow. With respect to breast cancer risk, and so this very much relates to treatment with radiation that includes breast tissue. You can see kind of on this picture here that the amount of radiation, depending on how much we give, it can be variable how much breast tissue is affected. And so as radiation has improved, it has allowed the radiation oncologists to be more precise. They can be more 3-dimensional, and they can be more, involved site than they used to be. So less breast tissue is being radiated now, even when we give radiation, than historically, but there still remains a concern. And so what about early breast cancer screening? And so who needs earlier screening? So generally speaking, there is some discrepancies with respect to what the recommendations are here. But most places do recommend that earlier screening should happen in females who received radiation that included their breast tissue before age 30. It says here with a dose of more than 10 gray, almost everybody who had radiation for lymphoma will have more than this dosage. And so generally speaking, the guidelines that we kind of follow are if there's been radiation that involves breast tissue. So anything that includes kind of the chest, the armpit is going to include some breast tissue. So when should screening start? This is where there's discrepancies, but generally it states at age 30 or 8 years from the radiation, whichever is later. And that screening should be with MRI and mammography, because mammography alone is generally speaking not adequate for younger patients' dense breast tissue. It's also very important though to recognize that even if you haven't had radiation, then the age appropriate screening for breast cancer should be done. Currently, this is age 50, but I think there is a lot of discussion about shifting that earlier for the general population. And studies have shown that people who are survivors of lymphoma do not always have their routine screening, even when it's just a general population age group recommendations. So in terms of the other second cancer that's seen commonly is colorectal. And while we don't treat a lot of patients with abdominal or pelvic radiation, this is a risk factor. And so patients who have had radiation to this area should start screening earlier, within 5 years of the radiation or by age 35. How to screen? So for most patients that are at general risk, haven't had radiation, then it should be as with general patient population with the fecal test starting at age 50. But for higher risk patients, so those who have had radiation, generally it's recommended that screening occur at the younger age with colonoscopy. So what can we do to reduce the risk of second cancers? It's all pretty straightforward. The biggest thing is smoking cessation. But we do know that other lifestyle measures can decrease risk of breast, colorectal, as well as other cancers. And so maintaining a healthy weight, exercising, and minimizing alcohol intake as per the current guidelines helps decrease risk of second cancers. What else can be done? So the other thing is that AYA cancer survivors are at higher risk of developing human papillomavirus related cancers. And so some patients may have already been vaccinated in school. There's a school-based program that vaccinates in grade 4, but just depending on the age group, some people may not have received it because it may have started, after they were in grade 4. And so this is very effective at reducing HPV-related cancers and would be recommended if it has not been received already. Just going to talk a little bit about psychological effects in survivorship as well. So these are most prominent within 2 years of a cancer diagnosis, but that doesn't mean they go away later. And so within 2 years of a cancer diagnosis, there's a significantly higher risk of anxiety and depression in adolescents and young adults with lymphoma, and a higher risk of substance use as well. As I said, these issues do not necessarily go away. They may become less frequent with time, but there's a lot of studies that show there's a lot of late psychological effects of having had a cancer diagnosis at a young age. Sleep problems are extremely common as well, and that often plays a role in exacerbating fatigue, and body image concerns are very frequent. So we kind of have a window of opportunity to help our patients with intervention and prevention. And hopefully there's resources for people and screening being done at appointments to identify who needs assistance. Brain fog is one of the things that can really exacerbate the psychological or emotional effects post-treatment. And so this is a common problem where people feel like they, often they tell me they just feel like their brain is slow now, or they can't concentrate, or they don't feel as smart anymore post-treatment. And thankfully, this generally gets better with time. That there is no one treatment for it, unfortunately. We do have some programs that work on counseling-based methods to help people overcome, but a lot of it is making sure depression, anxiety are adequately treated, making sure you're getting good sleep, making sure you're eating healthy, exercising. And so there's no one good treatment, unfortunately, for brain fog. In terms of overall treatments for psychological effects, there are sort of medications and non-medications that can be used. Often these really should be used together. Honestly, I think everybody should have the peer support groups, counselor services, etc., recommended to them. But sometimes medications are also needed, even if it's just short-term, to help with treating the depression or anxiety that's come up post-treatment. Talking a little bit about physical effects, so long-term. So fatigue is a very common one, and this can last for years post-treatment. There's usually no one kind of root cause, and it's can be very challenging for patients. Hypothyroidism is something that we see fairly frequently post-radiation to the neck. So it's important that patients that have had radiation that includes their thyroid glands, so the middle of the neck, have their thyroid function tested at least yearly or sooner if there's concerning symptoms. Many patients who have a history of lymphoma as adolescent and young adults have bone health issues, so most commonly osteoporosis. This is more common in patients who have received intensive treatment, including transplant. Heart disease is more common in survivors of lymphoma as well. We'll talk about that a bit more detail in the next slide. Neuropathy is a long-term complication in many patients that they have to deal with, and we've already talked about long-term issues with fertility as well as sexual health. So, heart issues among survivors. So we know that risk of heart disease and stroke are several-fold increase in survivors of lymphoma. A lot of this does relate to radiation, but chemotherapy as well contributes to the risk. What can be done? It's basically very similar to generally decreasing risk of heart disease in the general patient population. I think that we just have to be a bit more strict and aggressive with our prevention strategies in the AYA survivors. And so being aware, having blood pressure and cholesterol as well as diabetes controlled pretty intensively, and regular exercise is very good for preventing cardiovascular disease. And so, sorry, this should say visiting family doctor at least yearly for regular assessment is required long-term. So it can't obviously stress enough that regular exercise is very important. There's many studies that show that this improves physical as well as psychological effects post-cancer treatment. It can improve neuropathy, brain fog, all sorts of things. And so this should be sort of something that is recommended to all patients post-treatment. So with respect to survivorship care needs, I think part of what we're hoping to do today is just raise awareness, education of patients, education of care providers, We should collaborate with other specialties as needed. So for example, fertility specialists, hormone specialists, bone health specialists, etc., as well as other disciplines. So physiotherapy, dietitians, our psychosocial counselors. This is very important for the long-term care of the AYA patient population. Generally speaking, people are not followed long-term at the cancer center post-cancer treatment. And so it's very important to have a care plan communicated to the patient and the primary care provider. Hopefully this care plan makes recommendations regarding surveillance for late effects, such as breast and colorectal cancer, and makes it clear whose responsibility it is to follow these screening recommendations. So in conclusion, lymphoma is a common cancer in this unique patient population. And there's many impacts that either we don't see in other patient populations or are more prominent. It's important to recognize that survivors have long-term effects. And I would like to thank a colleague, Dr. Sapna Oberoi, who has shared many of these slides with me today for use in this presentation, and open up for questions, please.
Thank you, Dr. Skrobeck, for that overview in regards to the AYA population and just diving into the unique factors affecting this population. I know you did include a few factors like fatigue and sleep health, exercise, and things like that. On day 3, we do have specific webinars that will be talking about those exact things. So I encourage you to stay around for day 3. And with that said, just a reminder to the audience, if you have a question, please be sure to enter it in the chat now, and we'll try to get to as many questions as possible. So one question that came in, you were talking about neuropathy. So this patient said that they have severe neuropathy, and what treatments are currently available to help with this?
Good question. So there's 2 parts to neuropathy. So one part is the pain, like so the tingling or shooting, laser, hyper, you feel very sensitive. So the painful component of the neuropathy is best managed with drug therapies. And so drugs like, there's a drug called duloxetine or gabapentin or Lyrica are kind of our most common treatments. It does not bring back the sensation, but it helps make it easier to cope when people have painful neuropathy. Some patients' neuropathy, though, is not the pain that bothers them, it's just the actual lack of sensation. And so how that affects their balance and everyday life and functioning. There is really no great treatment for. Thankfully, most studies show that neuropathy decreases with time. So if we look at the treatment, for example, in Hodgkin lymphoma with BV-ABD, we see a lot of neuropathy, but it continuously decreases even as much as 5 years later. The severity of the neuropathy is dropping, thankfully. There's no good way to reverse it other than time. Exercise is probably the most beneficial thing for helping with the balance. It doesn't necessarily repair the nerves, but it helps everything else compensate for that loss of sensation. Other things that are often mentioned are acupuncture or like cold therapy. Those treatments is unclear how much benefit they have, but I tell patients they can certainly try, for example, acupuncture, but I'm not convinced it's going to be of significant benefit.
Thank you for providing information on that. And going into the next question, do chemotherapy regimens differ for AYAs compared to other age groups, and what factors influence these decisions?
Also a very good question. So yes, some of the chemotherapy regimens in quote unquote pediatric patients So like 15, 16-year-olds are different than what we give in adults. And this is something that we hope to change, to be frank, because there's no reason that they should be different. Generally in lymphomas, the pediatric regimens are a bit more intensive. And so the concern would be that of the late and long-term effects of being more intensive than is required. But that's happening less and less, thankfully. Otherwise, once you hit like age 17, 18, generally speaking, the regimens are going to be the same. But if there's uncertainty about sort of, if a patient has a very a high-grade lymphoma, and you're in the AYA population, I'm probably going to, talk to you about a very intense treatment that I may not discuss with someone who's in their mid-60s with the same diagnosis, because they would not be able to tolerate it. So generally speaking, it's the same, but depends at the same time.
Okay, and we'll just take one last comment/question. So this patient said that they were diagnosed with lymphoma and they're made to start treatment right away, and no one told them about how treatment would affect fertility. In this regard, do you think there is a gap that exists in terms of educating patients on their treatments and side effects, and how do you think this should be dealt with?
Good question. So yeah, I think this is obviously a known thing that sometimes fertility isn't discussed. I think that it happens, pretty commonly when patients are really sick, and the physician, just needs to get them on treatment very quickly, and doesn't feel that fertility preservation is practical. But I think, like we said before, I think it should still be acknowledged that it's something that, may impact fertility, but we can't, but unfortunately, we don't feel like there's, a window of time where we can, delay your therapy. What can we do? Well, I think that the AYA programs in the various provinces have really tried to increase awareness that patients want to have a conversation. Whatever the decision is made by the patient or the care provider, they want it just to be acknowledged, and be aware of the possibility. But I think there's still a lot of room for improvement.
Yeah, we've definitely also heard from patients with similar experiences, so definitely there's need for more conversations in this regard. We also have another question that came in saying, how much do genetics play a part in lymphoma diagnosis? I have lymphoma and would like to know what are the chances of my 2- and 4-year-olds of being diagnosed with lymphoma later on in life?
So thankfully, the risk is fairly small overall. For example, in non-Hodgkin lymphoma, the average Canadian has about a 2% lifetime risk of lymphoma. And we know that there is an increased risk that runs in families, but that would sort of increase the risk by about 2-fold. And so, not a huge increased risk from the general patient population. Hodgkin lymphoma is unclear. And the risk overall of Hodgkin lymphoma in the general patient population is less common.
Perfect. And that's the last question that we had in the chat. So with that said, I would now like to direct the audience to attend the next session titled Targeted Therapies for Lymphoma Patients, including BTKIs, bispecific antibodies, and BCL2 treatments. Thank you, everyone, and see you there.